had difficulty working on a new machine because the system did not have the presets they want. While to some degree this is true, a system can be set up very poorly. Generally, all machines have a default setting you can go back to which aren't horrendous to use. What we should consider a preset to be is a starting point, not often the same place we end at. Now, I'll throw in a few analogies during this lecture. I find they work well in helping bring in context to sometimes a very foreign topic to people in physics. By hopefully making these concepts a little more relatable, people can overcome their fear of physics and find it no more difficult than any other topic in learning, such as anatomy or geography. So getting back to our discussion on presets, let's consider an ultrasound machine to be a car. We take off on the lights in first gear and everything is fine. But we don't stay in first gear for the entirety of the trip. That would be very slow, noisy, and not very enjoyable. The same then for our ultrasound machine. We start with a preset, but not adjusting anything will lead to a less than ideal outcome. So the purpose of this lecture is not to talk about the basic machine settings, but more so to focus on how the settings affect our scans so we can deliver the most optimal findings and aid in diagnostic assessment. Gain. Gain in its simplest sense can be considered as amplification. Reflections from the body are returned to the ultrasound probe and the signal is then dialed to the desired level. You can consider the gain dial to be more like the volume control on your radio. Turn up the volume and the music gets louder, a fairly simple concept. So why is gain important? For a good number of reasons, some of which are more obvious than others. Its main purpose is so we can actually see what's being imaged on the screen. Again, a fairly simple principle. If everything is too dark, we won't see our structures of interest in the exam. Turning down the gain means that returning waves received with a certain low signal strength or amplitude will not be displayed on the screen. Conversely, if everything is too bright, detail may be lost in a screen of white, and this is why simply cranking up the gain does not always assist the image. Gain is equally applied to all received signals, that is, reflections from the structures of interest, but also artifacts and noise. Detail may be lost due to amplification as these undesired signals. If we listen to our radio in the country where the signal has weak reception, we may get interference on the listening station. Turning up the volume will amplify these unwanted sounds as well. Spatial resolution will drop when moving away from the optimal setting. Spatial resolution allows us to determine that two reflections are indeed from two separate structures. That is, both axial and lateral resolution are affected. As such, cranking up the gain is akin to increasing the spatial pulse length and beam width. Having the gain too high may mean the two structures blend together and can't be distinguished. Gain too low may mean we lose detail of the structure and assume them to be smaller than what their actual size is, if they can be seen at all. Contrast resolution will also decrease as we move away from the best setting. Contrast resolution allows us to distinguish that two structures, not necessarily adjacent to each other, are actually different. Turn the gain up and the brightness may become so overwhelming to make both structures look the same. Turn it down too far and again we get a similar effect on the other end of the spectrum. It's important to note that gain affects the image in its entirety. Over the years, I've heard sonographers try and educate others that gain setting should not go above or below a certain value. This statement is not correct. Gain should be applied to whatever value makes the image acceptable. When dialing the gain, we need to take note of the setting, but we do not let the value direct us. Power. Power relates to the strength of the voltage signal that is applied to the probe crystals. You could consider the probe to be a gong or a bell. The harder you hit the gong with a striker, the louder the ring. Now there are a few important considerations for power. Ultrasound waves attenuate or decrease in amplitude the further they travel. Greater power settings allow for increased penetration into the patient. Beyond a certain depth level, detail received may be low or even lost from the image if power is insufficient. We know attenuation is linked to frequency. If we are at maximum output and still don't have the penetration we need, then the user needs to consider reducing the transmit frequency or selecting another probe with lower band of frequencies. Be aware that on some systems, the maximum value for power is 0 decibels, and then lowering the settings down into minus decibel values. If the power setting is too low, then detail may not be demonstrated on the screen as returning signals are too weak. To attempt to display structures of interest, the user may increase the gain up to amplify the returning signals. However, this may have the undesired effects, as mentioned previously, of increasing noise and artifacts being shown. It is important to note here, then, that gain and power, while both increasing brightness on display, they are quite different. Power relates to transmit, and gain relates to receiver. Therefore, it is important to note that if power setting is set insufficiently low, then no amount of gain increase can improve the image beyond the depth of penetration. Consider we are listening to the radio station, again out in the country this time. If we are out of range, then turning up the volume will only increase the amount of static hiss, not the music we are attempting to listen to. The louder we ring the crystals by applying a larger voltage, the larger the delivered spatial pulse length. This affects our spatial resolution and specifically axial resolution. The ability to determine two structures as being separate vertically in the image is therefore modified. Increasing the power increases the amount of ultrasound dose given to the patient. This is important in relation to undesirable bioeffects such as cavitation and heating. The different imaging modalities will have varying levels of acceptance, such as cardiac has low risk of cavitation effects, and blood moving through the structures mean that heating effects are reasonably low. The tolerance for obstetrics is far lower to be safer for the child. Also be aware that imaging setting we're in will also have a significant effect with this, in that pulse wave Doppler gives a much larger dose of specific ultrasound in an area compared to 2D imaging. Here we'll talk about TGCs, time gain compensations. So the greater the depth in the image, the greater the total return trip travel time. We need to compensate for the imaging getting darker at greater depths. We know that ultrasound beams attenuate the further they travel. TGCs can be used to adjust gain at specific depths to correct for this. These sliders are also put to use when ultrasound beams travel through structures of various acoustic impedance. Uniform changes in brightness are not always the case, so we need to adjust these settings accordingly. If waves travel through a fluid-filled structure, such as a cyst, then echoes beyond the structure may be displayed as brighter. This is also known as enhancement artifact. In this instance, the TGC beyond the interface change may need to be brought back in order to obtain uniform brightness on the screen. Conversely, we could image through a dense tumour that may highly attenuate and lead to shadowing artifact beyond the structure. In this instance, the sliders need to be pushed rightwards to increase the gain beyond. To ensure we have obtained the optimal image, the sliders are used to avoid enhancement and shadow artifact, as mentioned with the previous pages discussing gain. Set inappropriately, we can lose spatial and contrast resolution. Some systems have the ability to adjust lateral gains. This has the same effect as adjusting TGCs, but instead of depth gain being adjusted, the effect is upon a few lines of sight at various positions left to right across the display. This has the advantage when a structure partially covers the imaging field of view. To simply adjust the TGCs would increase the gain across those specific depths and potentially enhance ultrasound signals that did not travel through the offending structure. LGCs in this instance would best target in resolving this problem. Most machines these days have an automatic gain function such as TEQ, iScan, and ATO. The system may try to uniformly adjust the gain for the screen, either at the press of a button or with automatic and constant updates. These functions work very well and may adequately adjust the display for us. However, they are not a replacement for our gain settings. A user will often be able to override this process and improve the image to the liking or, in a way, best display the point of interest in a study. Here is an example when an automated gain setting has been used. Overall, the image quality is fine, but detail to the left of the image is lost. This is the area of the right ventricle in short axis, and it is desirable to obtain this detail in a routine exam. Had the sonographer bumped up the sliders of LGC that affected the left of the image, we may have been able to see the detail of the heart wall. TGCs could have been applied for these depths, but that would over-enhance the other structures which have good gain settings. Turning up the overall gain would similarly have undesired effects for the rest of the image. Dynamic range and compression are pretty much used interchangeably in ultrasound. They are subtly different, however. Dynamic range is the range of grayscale that will be applied to the image. It determines the range of returning signal amplitudes that will be displayed on the screen. The greater the dynamic range, the more the number of grays that can be displayed. So higher settings will lead to a softer image appearance on screen. When dynamic range is reduced, the number of grays applied to the returning signal's amplitudes is reduced. The image will take on a much more black and white only appearance. Compression is a function which is, however, inversely related. As we turn up the compression, the amount of compression being applied is reduced, so the image appears softer. Conversely, reducing the value will apply greater compression, and again we can have a much more black and white image at this end of the extreme. Compression applies a process of decreasing the differences between the smallest and largest echo voltage amplitudes. So the effect on screen of dynamic range and compression, as discussed, is similar. How the machines are about applying these functions is slightly different, however. The most obvious effect of adjusting the setting is that contrast resolution will be affected. Turn the compression up too far, and the image becomes soft and fuzzy, and distinguishing structures as being different becomes difficult. The same effect as we move to the other end of the spectrum then. If we reduce the setting too far, then the same shade of grey may be applied to two structures and make them indistinguishable. This setting also has a brightness effect. As you rotate the dial to increase values, we will notice that noise begins to appear in structures that should be fluid-filled and not have echoes there. Conversely, by decreasing the value while imaging a structure such as the heart, we will see that the walls start to appear darker and harder to visualize as the number of grays being displayed is reduced. To put the principle of dynamic range into context, think of having a pencil case with 30 colours. The 7 colours of the rainbow, plus many shades and combinations of the colours in between them. This represents a high dynamic range. Now if we take most of them away and leave only 5 pencils, you'd have a much reduced colour palette, and some combinations of colours are no longer possible. As a general rule of thumb, the compression goes down in a technically difficult patient to help delineate what may be blood, vessel or a thrombus against the noise of what is usually a higher gain setting for these patients. High quality imaging affords higher settings and a smoother image which can improve contrast resolution significantly. Do consider, however, that if compression is adjusted, then gain may also need to be tweaked along with it. Frame rate. While this feature cannot be directly adjusted by a dial or a button, there are a number of settings that will influence what the frame rate value is. Frame rate is the number of sweeps across the 2D imaging plane that a system will perform per second to generate the image. The unit of frame rate is the same as the transmit frequency, Hertz. However, the maximum frame rate achieved on a common system these days is never above 200 Hertz. The frequency, of course, on imaging probes is in the order of megahertz, such as 4 million hertz. Frame rate is influenced by a number of factors, which we'll discuss now. The size of the field of view in both depth and width plays a significant part. As the depth is increased, we must wait for returning echoes before new pulses can be transmitted. Not to do so creates range ambiguity, and we may display returned echoes from structures at the wrong depth. While common machine and probes have multiple beamformers to keep the frame rates higher and reduce this effect, we are still limited by the speed of sound moving through tissues at an assumed 15-14 meters per second. Therefore, the deeper we image, the firing ultrasound beams is less frequent and the frame rate decreases. A similar problem exists when we increase the field of view and add more lines of sight. By adding these additional lines of sight, we need to wait for the operation of these to complete before the system commences a new sweep of the sector. Therefore, again, the frame rate will decrease. Line density can be adjusted. Increasing the line density, as it suggests, increases the number of lines of sight in a specific field of view. More lines of sight mean more time required for the transmit and receival of sound waves, which in turn will lead to a lower frame rate. By decreasing the frame rate this way, we have adjusted the system for improved spatial resolution. A trade-off then exists between temporal and spatial resolution, and we must adjust settings to observe structures of interest, such as fast-moving cardiac valves will need high frame rates, while a rather static liver does not require high frame rate. Increasing the amount of focal zones will decrease the frame rate. 2 focal zones may mean 2 pulses are required per line of sight, and as a result, the frame rate will decrease. Again, the trade-off between temporal and spatial resolution is present. Introducing a second imaging mode will decrease frame rates. One of the most significant impacts that can be made to 2V frame rates is by turning on color Doppler. The system must alternate between 2D and color beam formation. Frame rates as high as 100 Hz can easily be trimmed to 20 Hz or lower. Here, the temporal resolution can be impacted significantly, so much that brief color flows or fast motions on the 2D image could be missed as the system can't sample the field of view with the frequency required. Most machines these days can attain frame rates above 30 Hz in all modalities for 2D imaging. The system will often cap at 30 Hz to reduce data storage, so anything above this is acceptable. Problems occur when we image very deep into the patient or apply features such as color Doppler. In these instances, we should reduce the 2D field view size, reduce the size of the color box, or apply a zoom box, in combination or in isolation so the desired effects are achieved. So coming back to our color image, we saw that the frame rates were an insufficient 11 Hz, and the screen appeared jumpy as it played. In this image here, we are just interrogating the left ventricular outflow tract, which is displayed around the blue flow. We should consider dropping the depth, decreasing the 2D width, decreasing the color box depth, and decreasing the color box width. In doing so, the frame rate increases to 37 Hz. Zoom is a function we're all familiar with, and as we know, comes in one of 2 forms. Read zoom is simply a magnification process of the information that's in the system memory obtained from the field of view. It does not alter spatial resolution, and despite the box creating an effective smaller field of view, the frame rate does not adjust. Applying a read zoom is like pinching and pulling a tablet screen. The object appears larger, but the resolution stays the same. If done to a significant extent, you may notice the image or text become pixelated, as we see in this example here. Read zoom is of benefit when trying to show a reading physician a structure of interest. It makes the structure appear larger and removes areas around the zoom box which may distract the eye. The more common form of zoom applied these days is right zoom, which performs a rescan of the area of interest. This zoom allows for more pixels in the scan converter to be used to generate the image and an improvement in spatial resolution and results. To some extent, increasing line density may also be applied. However, if you note that the frame rate increases significantly, then it's highly unlikely the machine is increasing line density, as this would lead to a negative impact on frame rate. In applying zoom, frame rates will increase as we have decreased the width of view and there is no need to wait for echoes returning beyond the depth of the box. So zoom has the advantages of increasing spatial resolution and temporal resolution. In this example, we can see that a tight zoom box has been applied. The frame rate has increased significantly. However, the box is so tight, it's actually hard to identify what we're looking at. Enlarging the box will allow for more detail to be shown and provide landmarks, while frame rates should still remain high. The main disadvantage is if the box isn't properly applied, then part of the structure of interest may be lost. Additionally, if there is pathology outside the zoom box view, this could be missed during the exam, as the sonographer may not have been focusing on the entire image when the zoom box is applied. In summary, for a good clinical exam, we should apply zoom where possible to keep frame rate and image quality high, with the understanding that any pathology or structures outside the box may not be seen, particularly if performing a panning motion. We're all familiar with pulsed wave and continuous wave Doppler, how the signals are generated, displayed on the screen, and the differences between each mode. Here we'll dwell on a few concepts, some of which you may not be familiar with, and how we may adjust the settings to optimize the display. We will also note the potential by-effects from this from a Doppler is higher compared to 2D imaging. This is because the ultrasound beams dwell along one line of sight, and in addition, pulse wave applies high voltage to the crystal to ensure the requirements for beam formation are made. Doppler has gain and compression settings just like with 2D imaging, and they require continual adjustment, particularly when the signals we are attempting to interrogate are weakly received. As mentioned with 2D imaging, over or under gaining is undesirable. Too high and we may not be able to distinguish what our trace is from the noise. Too low and the flow profile may be significantly underwritten, leading to underestimations. And as we can see in this image here, for the overgained one, we wouldn't be able to trace a VTI because we can't even see the signal as it moves towards the baseline. And while we look at the undergained one, while we can actually see a clear, defined flow, the velocity is significantly lower. Dynamic range, if adjusted to higher levels, will add more shades of grey to a weak signal and may make it easier to fill in a flow profile so a VTI can be accurately traced or the peak velocity be best determined. There may be a limited benefit of adjusting the setting when a strong signal is displayed on the trace, in which instance a lower setting may enhance the strong signal's flow profile edge. Two settings sonographers often don't adjust frequently enough are scale and sweep speed. Many times the eye gets used to seeing regular patterns and we may not recognise that something could be improved upon. Scale affects the vertical height that the flow profile occupies in the available space. Basically, we want to maximise this space so we can get the best visual representation and have the least margin of error with caliper placement and VTI traces. Another way to look at this is that maximising the flow profile with scale adjustment is like applying a zoom box in 2D imaging. The flow profile will appear larger in the spectral trace and become more readily identifiable. When we measure in 2D, it's preferred during a zoom. So the same principle really applies to a Doppler box as well. We will be able to be more accurate with our caliper position and error is less likely to be significant. Sweep speed is another often set and forget setting which should command attention. As a general rule of thumb, it's good to have 3 separate flow profiles on the spectral trace. This means if you get patient movement, respiratory variation, or an arrhythmia, choose either of the 2 profiles that look similar. The other is the outlier. If the sweep speed is set too fast, you may only capture 2 profiles. One has a high velocity and the other one is low. Which one is correct? This is significantly more difficult for a viewing physician to determine. An alternative is to keep the same sweep speed and take 2 shots of the trace over time, but no one really wants to double the amount of Doppler clips. Also note the individual Doppler signals are actually vertical lines rather than pinpoints. Increasing the sweep speed too high and it's impossible to determine a peak, as we can see in our first image, particularly the first profile. Also, as the lines are further spread apart at a high sweep speed, it may be difficult to determine the modal velocity, the inner bright part of the trace that is desirable to trace in most modalities. Decrease it too far, and it's very difficult to obtain a VTI tracing when drawing with a trackball. Again, it's easy to introduce error to the measurement attained. Also consider we may have technology available to us that makes life easier. Your PACS may have the ability to perform measurements on stored images. A point-and-click method for a VTI trace is significantly faster, easier, and more accurate rather than trying to attempt a trackball trace regardless if your dominant hand is used or not. Another fairly underutilized function, but handy one in the right situation, it's why it's a knob on the option list on the system, is reject. This function basically removes low-level signals from the screen, which can be useful if there is a lot of fluff along the outer edge of the flow profile that you want to trace a VTI over, or the peak velocity is lost in smeary haze. Adjusting the reject may remove some of these weaker signals created by few blood cells as outliers compared to what the majority of the red blood cells are doing, moving in one direction at speed. Just be mindful that overzealous use of this will underwrite the image on the screen, and like pushing the gain too far down may lead to the spectral trace looking dark and an underestimation of the velocities. And we can see this in the images here. Reject has been pushed too far down on the left image, while the one on the right has more desirable settings. Wall filter settings are good at also removing unwanted content from the spectral trace, but it does so in a very different manner to reject. This setting removes all signals from the trace at low Doppler shifts or velocities. This is good to remove structures such as vessel walls or heart chambers that will generate very strong signals but move at low velocity compared to blood flow. Therefore, reject works to remove weak signals regardless of velocity. Wall filter will remove low velocity signals regardless of strength. Generally, in most settings, the reject will be set relatively low. The wall filter can vary depending on what we are actually trying to assess. Typically, if it's a peak velocity, the wall filter can be high. But if we're tracing a VTI and we need to get down to the baseline, then the wall filter should set low. In this example, we can see that the wall filter is particularly high and we can't see the flow profile getting close to the baseline at all. When looking at peak velocity, we can afford high filter settings. Just said that. When looking at peak velocity, we can afford high filter settings as we aren't concerned with flow in and around the baseline. When assessing low flow velocity, or looking to trace a VTI back to the baseline, then the filter setting should be low to allow accurate tracings. Gate size is another important feature to consider. When in pulse Doppler mode, the beam moves up and down the entire line of sight. However, the machine will only listen at a specific time interval, the range gate. Decreasing the range gate makes the sample volume more specific. This is useful if there are two different flows in this field of interest. A smaller gate size will hopefully obtain only the desired flow. Increasing the sample volume is used when attempting to gather low flow or stroke volumes, or when imaging deep in the patient and image quality is poorer, which also means Doppler information is lesser quality. In the example here, assessing a pulmonary vein, an inappropriately small volume has been applied, and incomplete flow profiles are seen throughout the spectral trace. Color Doppler is another application of pulse rate Doppler, which is however different from its original mode. The color box appears as an overlay of the 2D image, and the machine works by alternative lines of sight with both pulse wave and 2D. In addition, we must collect more than one sample volume down each line of sight. We are sampling a range of Doppler shifts rather than at one specific point. As mentioned on previous slides on frame rate, the system is performing these multiple tasks and has a significant impact on the frame rate that we see in the display. So we can see how many of the functions of the system are interlinked, and adjusting one function may have impacts on other settings of the machine. The number of sample volumes down each line of sight allows for the determination of the mean Doppler shift and therefore the mean velocity in that area. This is again different to traditional pulse rate Doppler, where we're looking at absolute velocity. The system is typically optimized for dialing up the color until the color noise is seen on the display, and then rolling it back until random noise is reduced or removed completely. Just like with 2D gain, we can significantly overgain and make the detail difficult for us to determine, or undergain, leading to loss of information displayed. Ideally, the gain should be adjusted for each new structure investigated and each new window we interrogate. it's unlikely one setting is sufficient for a scan, and a set and forget principle is less than desirable. We can also see that colour pixels are much larger than that of 2D. In many instances, colour may be displayed outside the vessel wall or chamber. Colour may also overwrite the 2D display so that tissue information is lost. To combat these problems, white priority can be adjusted. As the name suggests, it gives priority to what is displayed at various levels, colour or 2D. Please note that I've seen questions about white priority appear in many exams, and very few candidates know how to answer this question properly. It's a function on the machine, and yes, while it may not be used frequently, it does have a purpose, and consequently knowledge about that must be tested. Adjacent to the priority scale is colour scale. It determines the maximum velocity for flow in each direction before aliasing is seen as a result of the Nyquist limit. In cardiac imaging, it's desirable for the scale to be set high, otherwise alias is seen on just about all flows within cardiac chambers. However, it's important that if we're investigating flow with low velocities, that the scale is reduced. As mentioned previously, if we have a pulse-based spectral display, it's undesirable to have a very large scale and small profile filling that spectral display. Detail is lost and measurements have lower accuracy. Same for colour. A very high scale means that a very small section of the colour range close to the scale baseline in that direction is used to depict the flow. The detail may be hard to depict or lost altogether. As seen in the images here, the left displays very little colour information. The scale is set high at 69 centimetres per second. The image to the right has a smaller scale, set to 30 centimetres per second, and we can see that colour is much more significantly present within the colour window. Another detail that can be attained in colour Doppler is the variance. A large variance indicates a wide range of Doppler spectral shifts or velocities. This colour map is not always turned on, but has specific use in vascular and cardiac ultrasound, where variance is useful when assessing stenosis or regurgitation. The function allows for the overlay of green to the colour display. The combination of green and red makes yellow, and the combination of blue and green makes cyan. The brighter the colour at its extremes, the greater the variance. The variance can also be applied as just a green overlay to the colour. Regardless of the direction of flow, a green tint is applied. This option is often less desired as turbulent flow blooms in areas of green and detail of flow can be reduced. It is more common that the green is blended to the forward and reverse flow so we can see direction of flow and the amount of variance in the samples. Transmit frequency is a setting that I've seen many sonographers apply incorrectly. They'll often start a scan and select directly into penetration mode. As the name suggests, penetration mode allows for ultrasound to interrogate greater depths or traverse highly attenuating structures. To do this, a lower transmit frequency is used. The lower the frequency, the lower the spatial resolution. As seen in this CCTV image, the lower resolution does not allow to identify who the intruder is. Higher resolution settings would be desirable. So most systems these days have a broadband transducer, and starting in the middle range is often best. If you have a patient with good acoustic windows, then consider increasing the frequency. If the patient's quality is low, then consider decreasing the frequency. To start with, low frequency leads to lower spatial resolution, and should you have a technically difficult patient, there is no further frequency ranges to play with without actually going and changing to another probe. By adjusting the frequency, it is very much necessary then to adjust the gain and dynamic range settings, as it is highly unlikely that these settings will be consistent through the various modes. Harmonic imaging is tied to frequency, as it works on the principle of listening to the resonating frequency, that is, double the original transmit frequency. A 2 MHz transmit means a 4 MHz receiver. While the amplitude of the returning echoes are lower, There is significant benefit with improved signal-to-noise ratio, and therefore a much cleaner display. Be aware that harmonic imaging increases the spatial pulse length and can make structures appear thicker. This may be of importance when assessing intimal wall thickness or valve leaflet thickness. If the image quality permits, in some instances it may be beneficial to turn off this feature for comparison and then just image with native frequency. In summary, we've covered many of the common machine settings in this lecture. What is the effect when the function is activated and adjusted, and how this is reflected on the displayed image? Importantly, we can assess how these settings can be best put to use to optimize our study and potentially any diagnostic findings. The one take-home message to remember is that most of these settings are not set and forget as part of the machine's presets. Particularly if you're a trainee sonographer, spend time to explore these settings and how they can benefit you. Becoming adept at manipulating the machine gives you a particular advantage when a challenging case is at hand. You will also be able to impress your peers and also make your work that you perform easier. A lot of other items in there. We would like to follow up with your particular advantage when a challenging case is at hand. You will also be able to impress your peers and also make your to follow up with lectures that we've provided here online today.
Thanks, Adam. Can you hear me okay as well?
Yes, I can hear you clearly.
Fantastic. We have had a question come in. I'll go straight into it. So the first one is, would you apply all the optimization techniques that you have described?
In a nutshell, yes and no is kind of the right response to that. So we understand that we're time limited as sonographers. We've got a certain amount of pressure when it comes to actually doing our workload. So yes, we'd like to apply a lot of these techniques that we've actually described about, but sometimes in the real world, it's just not particularly feasible. So if you do have the ability, do actually look at some of these enhanced optimization techniques and what it can actually do for you and how it can improve things. But we understand that no, not all the time we can actually employ them. Consider your ultrasound machine to be like a toolbox. So you could pull out a hammer. A hammer might be pretty good for putting a nail into a wall. It might do an okay job for putting a screw into a wall, but a hammer's not going to be very good for bashing a piece of wood into two pieces. A saw would be a better task for that. So consider that you have a toolbox and you've got a range of tools. You've got the screwdriver, you've got the saw, you've got a lot of other items in there that you'll pull out for the appropriate purpose. So use the appropriate tool for when it's actually required.
Fantastic, thank you. Our next question, Seamus has said, thanks Adam for an enlightening talk. Is there a standard order of functions that you might alter in aiming for image optimization?
Yeah, so sometimes you actually work through a certain sequence. Otherwise, what you may do is you may optimize the same setting twice. So if we're looking at, say, 2D imaging, you'll want to start with your depth. Get your depth right, then work on your focus, and then you can look at your TEQs or your ATOs or your eye scans, whatever it may be, or sliding your TGCs, adjusting your gain, adjusting your compression. There's nothing worse when I see a lot of sonographers get a reasonable window, particularly when they're trainees, and then they optimize for gain, and then they realize, oh, hang on, my depth isn't appropriate. They then adjust for that, and then they actually need to then adjust their gain further. Same if you're actually going to apply zoom. Sometimes when you apply zoom, because you're actually getting new lines of sight, scanning that new zoom sector, you may need to then further tweak your 2D settings.
Great. So that, I think, leads on to the next question here, where someone has asked, some of the settings that you described look out of place, and should they even use them?
So what this is about is not telling you how to actually run your machine. The purpose of this lecture is trying to open your perspective and get you thinking about how you should actually be using the machine. Some of the functionalities that are available to you, the settings I've actually described aren't purposely what you need to apply, but what you can consider as an option that may be there. Sorry, I lost my train of thought there for a moment.
Do you want me to repeat the question?
No, sorry. I was going off on a tangent there, and I've lost my train of thought. Sorry about that. You go with the question again. Maybe it'll actually trigger where I was actually trying to go with it.
No probs. Some of the settings that you describe look out of place, and should you even use them?
Yeah, so where I was trying to go with this is open up your perspective to actually think about why we use some of our settings. Be inquisitive. Ask your peers, ask your mentors, why do we do this, or why don't we do this? Use it as a process of justification, and there you can sort of understand a better reasoning of why we should actually have these settings or why we should actually apply those settings. So what I've actually described should actually open your perspective to that. It doesn't mean you actually need to use those specific settings I said.
Right, thanks. Yeah, it is important to look at things from a different perspective. Thank you, Adam.
Right.
Now, we don't have any more questions, but we do have a little bit more time. So if anyone does quickly want to shoot anything through for Adam, he can hang around for the next few minutes. I have just put on the screen just our upcoming webinars that are coming up in the next couple of weeks. And just to highlight, the next physics webinar is the Doppler principles one, where Dr. Rob Gill will be delivering that one on Tuesday, the 2nd of March, which is in a couple of weeks. But anyway, thank you, Adam, so much for joining us this evening.